So even a well-designed phase 3 trial can still have issues, like the wrong comparators being included, desirable comparators being excluded. For example, if you submit to NICE using an American trial, you might have comparators which aren't yet reimbursed in the UK. You can have heterogeneity in your trial population versus the target reimbursed population, and you'll definitely almost always have uncertainty around your long-term outcomes for OS and PFS. And this is an area where real-world evidence can really help fill these gaps. So what to do if you have irrelevant comparators or a comparator that you need isn't included? So as I mentioned previously, treatment pathways differ by market, and some treatments will be reimbursed in one market and not in another. So in these cases, you're going to lack head-to-head evidence. So you'll need to synthesize indirect evidence. Now, when it comes to indirect evidence, HTA bodies typically accept it, but historically this is focused on what I'm going to call traditional evidence synthesis methods. Things like Bucher indirect treatment comparisons and network meta-analyses, which typically require at least some direct evidence in order to build your evidence network with your comparators. However, this isn't always possible, and recently some other methods which do not require direct evidence have gained popularity, and these include things like matching adjusted indirect treatment comparisons, simulated treatment comparisons, and external control arms in particular, to name a few. These are all approaches where real-world evidence can be utilized and is really useful.